Hello, my name is Bob Mara. I'm the Assistant Director for the Division of Special Education, Indiana Department of Education. Welcome today to our broadcast on wraparound services. With me today is Nancy Mead from the Indiana Department of Health, along with Trace Benedict from the Hancock South Madison Co-op, and also Steve Schofield from Step Ahead from Hancock County also. These three people have been very instrumental in bringing together services for children and family in Indiana. And our initiative today is to show you the different types of initiatives that are happening across agencies and also from the state and local level to bring services to the children and families that we all recognize have some issues out there. If I can show you graphic number 1, which will really show us the current system of getting services to children and families. It's a system that is based on categories and one that is very difficult for not only the family to access different services, but also people at the local and state level to coordinate those services. And these are the things that we would like to point out today in our initiatives of how these people have taken the local and state resources and looked at individuals and their families on how to coordinate services. Up there are some of the limitations and characteristics of our current system. We go on a long time talking about that. But the model that we would like to share with you is also shown on graphic number 2, which is talking about the family as the center and the services around the individual or the family, and also for this broadcast and things that we've done with the Indiana Collaboration Project, we have not defined family. That's for the local or the individuals around those people. It could mean one, it could mean several of those types of individuals in a grouping. We do not want to define it. But to start our thoughts off today, I'd like to go to Steve here. And Steve, can you kind of give me an overview of some of the initiatives and the guideline best practice book that your initiative dealing with some of the residential and then alternative residential services that you've developed with multi-agencies? Can you give me an overview of what we've done?
Well, basically one of the things that we're doing right now is, or have developed, is the Guide to Wraparound Planning Manual, which is really more of a primer manual. I like to look at it as for the beginning and practicing musician kind of manual, where someone who was just beginning something like a care coordination team that wanted to do wraparound planning could use, or a team that had been doing something like that for a while and wanted to add some new ideas or new skills to the repertoire. It's more of a, I'm used to the how-to books of the Time Life series where it had pictures and step-by-step, and so that's pretty much the format that it's set into, and it's also focusing on tools that you can use for care coordination and wraparound planning. You don't need all the tools to build a house that's in your toolbox, or you don't use them all at the same time as you wouldn't use all the tools that are in the manual at the same time. If I could look, for example, if we could look at the first graphic, which gives pretty much an overview of the concepts that are in there as far as the steps. Step 1 would be to initiate a care coordination team. Step 2 is establish organizational procedures, and there's some things that you could do, and different teams may decide to do them or not do them, such as mission and vision, meeting procedures, confidentiality procedures, and on to the next graphic, which would be, for example, interagency agreements. Now, a team may decide to do that. They may decide that that's something that they need to do to feel like cohesiveness among the group. There's also an example book that accompanies the manual where they can just go to the example book and find some agreements that have been written by other counties, use those agreements rather than start from scratch. That's pretty much the way it's set up. It's supposed to be about as user-friendly as possible if a team wanted to do care coordination focusing on these multi-need kids, which are usually our kids that get placed out of county.
Okay. And Nancy, I'd like to turn to what you've been doing with the health department, because your model, as Steve was just talking about, multi-needs children that have many service issues, probably in crisis, and we're trying to look for that alternative placement. The initiative that you've been involved in really has to do with prevention, early identification, same type of concept of bringing the right people together, but at a different part of the continuum. Can you, give us an overview of your program? Or?
Yes, I can. In the health department, we have within our projects, our prenatal projects, our child health projects, have for a long time had social service workers who, in fact, did some evaluation of families and referrals to other agencies. We have upgraded that a bit through prenatal care coordination and now through family care coordination to provide additional support besides just assessment and referral, such that we have care coordinators who will make home visits, who will provide additional education. The idea is that we provide services for the whole family, regardless of how the family gets into care coordination service, and we provide those services not just regarding health. We not only look to see that they have a primary health care provider, that they are getting their immunizations, that they are adequately nourished as the basis, as the foundation for health and well-being, but we also look at their social needs. Do they have their GED? Are they still in school? Can we keep them in school? So we're looking at the whole family. Do the children need to be in daycare or in nursery school? And this is a preventive effort to make sure we don't need as many of the services that the wraparound services will be talking about or have mostly identified in the notebook. We have expanded our family care coordination services then to collaborate with First Steps in their early identification 0 to 3 of children who are at risk or identified as being developmentally delayed, so that our care coordinators then can continue with the family they may have been working with in their health care setting to provide an IFSP. We have been working closely with children with special health care services to provide the same kind of care coordination for the special needs children, so that they don't have to be changing from one care coordinator to another just because they're going from one category to another, and so that we don't have 4 different people vying for their care coordination attention, and that they have one person that they can identify and call when they have a need that comes up. We feel that it helps minimize fragmentation of services, and that it will also encourage a better rapport between the care coordinator and the family that we're working with. Our focus is to prevent families from getting into overburdened situations that they can't deal with, and hopefully head off some of the problems that we see later on. The money that we put in now as a preventive measure is going to save a whole lot of long-term care efforts in the future, and so that's the basis on which we're working. We have not a lot of programs in the state of Indiana because we have programs coming out of our healthcare projects, but we do have quite a few trained prenatal care coordinators who can expand their services once we figure out how to do that in terms of financially supporting that effort. And so we're working to do that.
Where would they be located right now,
the ones that are trained for prenatal care coordination actually are located in every county. Many times there are multiple trained care coordinators. We have 700 to 1,000 that are trained and certified so that they can be reimbursed through Medicaid. And they come out of home health care agencies that are not-for-profits. They are in the hospital home health care agencies. Some of them are in the OB units of the hospitals. They're in our prenatal clinics. Some of them are public health nurses. There are some that are just doing it as an independent. So we have lots of opportunities to create systems to take care of the families that are there. I think there's more than enough work to be done at this point. We still are working to get it systemized.
Right. And so if I understand where they all are, then really in any part of my life, if I'm a young person that needs some of this help, I could be in the hospital, I could be in my community level, I could be a private person that maybe have been certified that found out an issue is really the contact point of someone looking at me, I come to them, or they find me out in one of these scenarios and say, let's start looking at a holistic plan for you?
Idealistically, we would like that to happen. The system is not well developed at this point. We're working on this county by county, which is why we wanted to be involved in this discussion today, because we would like for the health component to be included in whatever efforts are done with the wraparound service guidelines, so that it is the basis, so that even when these children get into school and into special education, health is not just something that is asked about through the parent, that it is an integral part to make sure that they are well fed. We know that health and nutrition do affect behavior, and that's kind of what we're dealing with here. We want to make sure that there's nothing missing in that area of their well-being as well. So we wanted to make sure that health is an underlying thing to be looked at.
It's that foundation for what we're really talking about. Trace, taken with Nancy's thoughts right there, and you've done a lot of work with the domains and stuff, can you share what we're really trying to get people to focus in on? I'm in special ed. I've been in there for 15 years, and I'm going to educate the child if he's learning disabled in this area, or in emotionally handicapped. And my training, my background wasn't to really share all the domains, so we don't focus in on that. And what Nancy's bringing is really a holistic child, holistic family. Can you share some light on what we're talking about with the domains?
Well, wraparound planning in a way is kind of a holistic way of planning, because it's a strength-based kind of planning that's based on the needs of the child and the family. And it is based on life domain areas. So like you mentioned, Bob, educators aren't just planning for the educational domain when the child and family's needs go beyond those 7.25 hours the child's in school. Wraparound planning is going to involve the areas of residential and family, social, educational, medical, psychological and emotional, legal, safety, and cultural. So that, for example, if I'm planning around the needs of a child, and often in our work you're planning around the needs of a child who would traditionally have been placed in a residential facility or a psychiatric hospital, and we're attempting to serve that child and family in their home community, trying to take advantage of the natural supports in that community. For example, one such child, we're able to, in the medical area, use the existing psychiatrist that was working with the family. And we were able to use relatives to provide respite for that family so that they could have a breather from the demands of raising a multi-needs child. We're also able to provide for an informal kind of counseling where the therapist works with the child in the community and gets them out, and in that way also meets some of the social needs of the child and teaching those social skills where the child will be using them. At the same time, if you're looking at the big needs of the family, there was a need for family counseling, and that's taking place in a more traditional setting at a local mental health center. And the educational needs, we were able to use a local alternative education program. So we took a child who traditionally people would have thought the needs were way too severe to serve in his home community and would have placed out of the community, and found a way by working together with all of the agencies in the community to serve that child and family in the child's home community so that he can keep his friends and he can keep the natural supports in the community.
Why would we want to do that, Bud? What I get all the time is, wasn't it easier just to pick up this child and remove this child into another setting that would have all the things that they needed in this residential treatment center? Why would I want to stay with this other approach?
Well, I think in the long run what we're trying to do is have a child that's going to be able to function independently as an adult. Instead of just spending their entire life in a residential facility, we want to take advantage of the natural supports in the community and maintain those throughout that child's life on into adulthood. And the other sad fact is that most of these facilities, when the child turns 18, they return to their home community anyway. So why don't we spend these years building for that moment?
Starting from there, building. That's
Yes.
right. Nancy, can you shed some more light on, because I know that the health issue is an important issue in this whole type of approach that we're looking at. And when we looked at our wheel, as you pointed out earlier, there's really several components that that relate to health, but some of the people that may be listening today really don't see that as the health issue. Can you shed some more light on that health side of this?
When we defined health in public health, we define it as not only physical, which I think you're referring to as medical, but also emotional and social well-being. And in that light, it really is a very broad base upon which to build all the other efforts in our society, really. Nutrition also is a part of that. I have to say that because I'm a dietitian.
It's all right. You can get
But
those
it is a
plugs in.
very a good basis. I mean, if we're not nutritionally sound, frequently we have behavior problems, and so we have to look at that also. Health has been our way of getting families into the support services that they might need, and then because we can focus on getting them into health care early, prenatal care, and following those babies along. Of course, we want to lower infant mortality rates and all of those kind of health status behaviors. But in the meantime, there's a whole lot of education that goes on between our care coordinators and their clients and the families that they're providing services to. And our hope is that the parenting information that's given or that's referred to the client, the basic health information will empower that client then to be able to support herself better. We have also been working with Healthy Families Indiana in terms of family support and preservation. So it really kind of flows together nicely. Early intervention will hopefully get kids started on a better foundation than they have previously had. And so when they start school, they may not have as many problems as we have found before. But they have to be healthy. They have to make sure that immunizations have been given, that they're eating well, that they have had physical examinations, and that there's nothing organically wrong with them before we get the psychiatrists and psychologists or in addition to working with that part of the medical community. Just the basic primary care.
So we're starting with the least intervention, seeing if that's okay, and then working to the more, sequential approach of saying, okay, now we know these things are okay.
We've ruled
it
these,
must be this or this. And
but we need to maintain that health. I mean, as you know, adolescents are notorious for not eating properly. So I mean, we have to make sure that all along their health is good. It's not just checking it off the list here and then going forth.
It's okay over here, but 3 years later isn't.
Right.
Steve, turning to you for a second, I want to ask you some questions about, right now we're probably all for an agreement that we need a systems change, and we want to look at it holistically around the individual family. I don't think there'd be a lot of people out there calling in today saying, no, we want to keep the old system, but you've done a lot of work on getting the systems or the agencies to work together, and I know that there's a lot of issues of turfism, sharing resources and blending. Can you, share with us some of your thoughts on how, in your scenario, you did bring the people to the table, and then the benefits of bringing the people to the table to say, wait, we live in this community, we all provide a part of this, how do we do this together, and maybe some of your insight of being with this for several years.
Well, really one of the first things was really to look at was what we wanted to do, what was our purpose, or to form any kind of group or any kind of committee. And then the next thing to do is we were looking at also kind of along with that is what kind of target group, what kids were we looking for, which with us it was more or less looking for kids that have been placed out of county or the kids that were coming back, because we had a lot of times a lot of problems. I've had some experience working in schools, and a lot of times the kids, they get placed out of county or in a residential placement, and they come back and we're not really sure exactly there hasn't been really good planning in the transition. And a lot of times the benefits of that residential placement may not have carried on when they come back. So then the next thing is we looked at who are the providers, who in our community are providing these kind of services and paying for a lot of these out-of-county placements, as well as who on those agencies would be a good representative for those. And from that point forward, we just discussed, basically held a meeting, and it was pretty universal. A lot of people saw a lot of the problems that were within the system. And we had a lot of the same kids, basically. Education had some of the same things as the Division of Family and Children. The names were real familiar, but we were all approaching them from a different viewpoint.
Were you getting different members of the family in the educational component while you were sitting down also, and then finding that DFC might have had another member of the family also?
Yeah, that's real common. It's a real common situation. Usually we would have the older kids because we see the problems from the school perspective, and then the DFC might have some of the younger kids that may be referred but through the neighborhood or through problems from that avenue.
So one of the key ingredients is that we all share the same mission or vision or objectives, whatever word I guess you want to use out there, saying we believe that this is where we need to address. What was the next step after that, after you came together and you realized same kids, same type of objective that we're trying to accomplish? What was the next level of thought then to accomplish?
Well, I think that the next level was breaking down just the barriers that have been built between us for years and years, where there's been different funding streams that have come down from this federal into the state and into the counties that have kind of built some artificial barriers between us. I will give an example. I was a behavior therapist in the school system for 4 to 5 years, and I had no idea who the director of the Division of Family and Children was until this initiative started going. And now, from that point forward, we developed an understanding and got to know each other as people rather than systems or parts of different systems, and realized we had a lot of things in common. And I think just breaking down those kinds of barriers and building trust was really one of the first initiatives. And then after that, is start looking at, as was in the first 2 graphics, or some of the things as far as developing our own mission statement and interagency agreements, or understanding on who's going to do what within these meetings.
Nancy, you had some similar situations then of bringing some agencies together. Is there anything different, or from your unique perspective through the health, seeing the same things as Steve did then, of getting people together and saying, we're doing the same thing. I didn't know you were out there doing that.
It's amazing what communication will do, actually. Bringing together First Steps efforts and Children with Special Health Care Services. And as I said, Indiana Healthy Families, or Healthy Families Indiana, is a pooled funding situation where MCH put money in, FSSA put money in. I think the Justice Department has supported this preventive effort for overburdened families. But yes, we have seen how much improvement can occur just by people knowing what other people are doing. I've seen that many times in Step Ahead. It's the same kind of process of bringing people to the table to discuss what is going on and what the barriers are. And when that occurs, we can get more done. If there's a trust that's built up, people then can allow the families to make choices as to who they would like to be their care coordinator, or with whom they would like to work to help facilitate whatever services they need. And I think that's the point. We need to let the family have opportunities to make choices and to do that, as coordinatedly as we can, because they don't really need to have 4 different people coming into their home.
Right. And we've heard lots of those horror stories of one care coordinator told me to do X, the other one told me to do Y, and they weren't really the same. And then you have this parent going, which one do you want me to do?
Right. And I think that also speaks to the need for some cross-training of people who are in the profession of care coordination. They need to know what services are out there. and what they should evaluate. For instance, that they should all evaluate their basic medical health services as well as their mental health efforts and services or needs of the client.
I want to go back to another question and see, and not in real detail, but you talked about the different agencies kind of pool some resources together. How did we accomplish that, and then how do we access those dollars? Are they individual staff people that are paid through those initiatives that are then cross-trained and go out and deliver the services?
If we are now doing some pilot projects with First Steps. In that scenario, MCH has, or First Steps wants to change its method of reimbursement, and so it's using the MCH clinics who have care coordinators to test run the reimbursement mechanism. And so what we have done is selected pilot programs that have existing care coordination services, have been funded for maybe additional staff through MCH monies. All of their care coordinators then have been trained in First Steps efforts, how to write an IFSP, for instance. And that training then will, when they have a child that is screened as being possibly developmentally delayed, they will be able to take that child as, you know, and take them through the IFSP formation and getting them into First Step services. The other scenario that we have done is with Healthy Families Indiana, and in that situation we simply put a pot of money into the Healthy Families initiative, and our money has been mixed with the other monies that have come in and have helped to fund the pilot programs around the state, of which there are more than 20, I believe, at this point in time. We have also been involved in the training of the family support worker. And incidentally, we have made sure that the training of the family support worker is essentially based on the same training that we give community health workers. And so the idea is that once things get started, these two groups can fold in with one another and expand the services much faster.
Okay, so you're talking about pool resources, coordination of training, which is really important, putting the people out. Trace, when you do wraparound, but it's really individualized in the sense of that individual student or child or family. Can you kind of explain to the people out there today what we're talking about, which is more individualized wraparound versus the system wraparound, where I believe they're probably doing the same thing in concept but on an agency level, and then on this one we're zeroing in on the individual child themselves?
With the wraparound planning, you design the plan based on the strengths and unique needs of the individual child and family. You tailor the services to meet those unique needs. So in order to do that, there are a few must-haves or key ingredients for wraparound planning. If I could have the graphic for number 5. The first one is a community team that Bob and Steve were talking about. The community teams are needed to track the services that occur for students and families across agencies. You also need the community teams because the needs of the child and family typically go beyond the area or the service area of any one agency. Like you discussed earlier, we've often found that a child with educational needs for planning is also a child that the probation officer is familiar with and the director of Division of Family and Children is familiar with. So we all kind of pool together our resources and our creativity to address those needs. So if I could also see 5B, resource coordination is also one of the needs because you need somebody to work with the child and family and to make sure that the services meet the needs of the child across time, so that as the changing needs of the family and child present themselves, the services reflect those needs, that they're responsive to the needs in a quick fashion. So if I could see 5C, in order to accomplish this responsive kinds of services, you need a child and family team. The child and family team, well, maybe I should speak more on resource coordination.
It's all right. Good.
Okay, the child and family team consists of the parents and the kids, if they can handle it, and 4 to 8 people who know the family best. And they're responsible for developing the wraparound plans, planning for crisis, supporting the implementation of the plan, accessing formal and informal supports, monitoring services, and inspiring unconditional care. Also, the child and family team provides the support for that family long after traditional supports are gone.
Yeah. Let me point out a highlight in the first graphic, too. What you're really saying in that, the concept here is that the parent and the child, if that is deemed appropriate for them to be part of the plan, is the key element of having them part of this, that it's happening with them instead of to them.
That's a very key point, Bob. And because the family is involved in the planning, and typically in the planning we will give them veto power over the different options we're looking at, they have the buy-in. They're more involved. They're going to be more involved in something they help to create. So, and that really is a key part of it. Traditionally, we've told families what's wrong and what they need to do. This is a total different way of looking at planning for children and families, where the families help create the plan.
What children would you see that have been involved in the actual plan themselves, and how did that help then for that individual child?
Well, I think, again, the more you involve the people you're planning around, the more accurate, the more it's going to meet their needs. So I think just children who are able to sit in a planning meeting, if they're very oppositional and it's just going to be traumatic for them to hear people talk about them, that's one thing. But if they can speak to their own social needs, if they can speak to what's going on educationally and how we can provide for that more successfully, if they can speak for, sometimes psychiatric care is being done and they're on medicines, they can talk to us about how those are working, and the more you involve the people you're planning with, the more accurate I think the plans will be. The more buy-in, the more involved they will be, especially if you're talking about teenagers and children who have a strong need for independence. I think it's very important to involve them in the planning.
So mom doesn't come home and say, we talked about you today and we're sending you to Colorado. Right?
Exactly.
And not understanding why I'm going to Colorado, just pack my bags up.
Yes.
Did you?
I was just going to add that those same kinds of themes are what our care coordinators in the preventive end are also using or should be using in terms of focusing on the family and making agreements with the family as to what their needs are and how they can best be met. And then they facilitate those care plans.
Yeah, also when we talked earlier, one of the uniqueness of your thing also would be that in our plan we're pulling down different resources, dollars per se, around that individual child and putting together a plan. You may also look into your community, as we talked about a stop smoking program that may not be funded through the parts of the thing that we talked earlier, Nancy, but someone would go out and find that program and introduce that parent to that program and saying, Bob, we need to get you in this program. These are the issues that are about that.
If that's where they are, if that's the point at which they're ready to stop their smoking, that would be appropriate.
They may not be there, we understand that. But if they're there, then again, that uniqueness of looking at what's in the community and how do we bring those services to that family.
Right.
Steve, could you shed some light on this? I asked Nancy earlier, where would this team pick me up? How would I get in this type of thing? If I'm a child out there, how would a team be formed to even get around me? Where would be the contact points?
Well, there's a difference between what Trace was describing as the family team, and that's really formed around the family. The family determines who is going to be on that team, and typically the general rule of thumb is no more than half the members will be professional, at least the other half would be family members or friends of the family. The team, then you have your community-based team, and that would usually, in small areas like in Hancock County, we usually have the directors of the various agencies, such as our director of special ed and our DFC director and our chief probation officer, and our director of our mental health center sit in on that committee. Basically, the flow of the system is that any one of those agencies can make a referral into the team, and usually your facilitator or your coordinator sits down with that person and determines, is this kid a part of our target population, or why we were formed? And then the very next process is if the kid is a part of the target population, then the referral is brought before the committee, and at that time the committee determines, is the kid going to be admitted into wraparound planning. Then there's some other options from that point forward. Are we going to hire a facilitator to do the team planning with the family, or are we going to do it more on an agency level, which is sometimes done, and have the family come in with agency members? And then basically the plan is developed based on looking at the life domain areas and what does the child need in these areas, and what's going to be done and who needs to do it.
Okay. Trace, could you give us some helpful hints on how to pull that together in some of your work on pulling the teams and the issues together?
Well, I think the first step is to just spend time together. I really think there's a developmental process in getting a community team together. We just had to spend time together to understand each other. And I think one of the things I'm most proud of in the interagency group I work with is that when we're planning around a child, every member of that team offers everything they can. It's not like, well, you should be paying for this or you should be paying for this. Because we've spent some time together and developed that trust, everybody offers what they can. It's a real, it's inspiring to see the different agencies pitch in around a family.
That's interesting that you bring up that, the word trust keeps on coming up from all of you again, and then getting to know each other. Nancy, in your experiences, were those, again, some of the key ingredients that you all worked on the local level of sharing and trust building, and then how did you accomplish that?
Well, in fact, for about 2.5 years in some areas of the state, we've had, and now all throughout the state, we have regional care coordination networking meetings to try to get particularly prenatal care coordination, but now it's expanded to family care coordination, started in more communities. And it was an opportunity for us to share with the care coordinators information that we're learning at the state level, and information that they may need to know for their job, but it's also an opportunity for them to share with each other the problems that they're having, the barriers that they're having, and in addition to that, get together at a county level to try to start coordinating the services within a county. This is still developing. We're still now just getting started doing this all over the state. In fact, our next round is in March. And we try to do it 3 times a year. In addition to that, then we've, in some counties, pulled together all of the care coordinators that are working in prenatal care coordination and or family care coordination to try to get them to network and advertise their services in a coordinated fashion so that physicians understand that they're available, and as well as the clients. And the hard-to-reach clients particularly.
Okay. You also talked that you had some guidelines developed on,
We have guidelines that sort of define family care coordination, what we, as an MCH service, expect a care coordinator to provide to a client. And we've developed those guidelines basically to help the care coordinators that are out there get an idea of what they're really supposed to be doing, and trying to get them out of this categorical kind of concept into the new, I think they're using the term paradigm of family-centered and uninterrupted, seamless service system.
Right. Instead of, we all know that we're different at the state level delivering that, but the parent's supposed to kind of look up and also not really know where those services are coming from, because that's not their issue.
Right.
Trace, turning to you for a second, Beth, we're talking about sharing, about bringing in all these people from these different agencies, and I'm going to talk about your son today. What about the issue of confidentiality, and how did you all address that? And I know that the Indiana Collaboration Project is working on a document to help share locally, this issue. But how did you tackle this locally? Because couldn't this get me in trouble if we bring everybody into the room and start talking about somebody's child and services or health records? How did you approach that issue?
It's a good question, Bob. Locally, what we did was we just made sure that informed consent was achieved, so that whatever agency was bringing the family to the table, we made sure that they had consent forms signed, and that those are monitored and updated. And as long as you have informed consent, and especially in a process where you involve the family in the planning and they're fully aware of what is going on, we really haven't had many concerns along the lines of confidentiality.
So with all the legal work, which is obviously really important here, and we got this document that tells us legally what we can do, bottom line ingredient here is if the parent's part of this, or the family's part of this, whoever that parent may be out there, or the guardian, or all those other good words we can use today, we're probably not going to run into that issue. So it goes back to one of those guiding principles again, is being part instead of something happening to you, is what you've seen happen on a local level.
That is the key.
Okay. We're not quite out of time yet. We're running down there. Steve, can you shed a little bit more on the manual that you all prepared, kind of the overview of kind of what's in there and how the folks can get a hold of that manual? I know we're in print right now, and we'll have this video to go along, but can you give us an overview of the manual of what you got?
Well, as you said, it's my understanding that the people that receive this tape, particularly the special education cooperatives, will also receive a copy of the manual. But generally, as I was saying, it was mostly a manual of tools to be used, mainly so each county or group can make their own process and provide guidance. I think it's direction but not dictation. Provide guidance on what you could do and what has been successful in other areas, but not to tell anybody this is the way that it needs to be done. And we have, at this moment, we've been doing some training. We have 5 mentor groups that we've been working with.
Can you share a little bit on what's happening with those 5 groups out there right
Well,
now?
we've been, basically, a lot of those are groups that have been up and running for some time, have been working with kids, and some of them were local coordinating councils or committees, and some of them just basically formed on their own, and they have been basically doing some planning on their own. What we were wanting to do is use those as mentor groups. I think everybody knows that change is difficult. But it does feel comforting to call somebody maybe that is a peer in your own agency that may be in another county and ask them, how did you do this? How did that work for you people? And so we have identified 5 mentor teams that will serve that purpose, and they've agreed to do the training or be through the training. I think we've had 3 trained already, so we just have 2 more to go. And from that point forward, we'll offer training regarding the manual, more intense training for groups that might just be one person in a county who may want to start a care coordination team for wraparound planning, and or it may be a whole county team and provide them that kind of assistance.
And also looking at the manual, that at least the draft that I looked at, was some people from out-of-state, what they've done, but also what has been done in the state of Indiana. So it's a combination of the two?
Oh, yeah. It's a combination. I think we've got a few counties, as I said, that are up and running, and they have like some of the agreements and their procedures on how things are going. So those are in there, as well as from the out-of-states, too.
When we look at the out-of-state perspective, where does kind of Indiana fall with this initiative? We in the middle, the beginning, the end, or are other states doing this?
I would say we're probably up in the top 20%, somewhere in there, as far as being. There's a lot of states I think wraparound may be a word that they use associated with their computer or something like that. But it's not been implemented in a lot of states. So I would guess we're probably up in the top 20.
What we're really talking about when we're talking about wraparound is really a concept of it, not necessarily. I know that people have equated it with where we started the initiative with the residential or quote-unquote S5, that you only can do wraparound services for children with disabilities that are headed for residential, and we kind of realize today that the concept's been happening in the health side of this for several years now of looking at the individual child. Those other states, are they looking at it as wide-based as we are, meaning from the prevention and intervention down here to residential, or are they focusing in on one end of the continuum also?
I think they're probably going in the same lines that we're going in right now. I think being here together today will help us realize what the left hand to know what the right hand is doing, so we can see what's going on in some of the other agencies and really build on that and end up probably with a better manual and material and process than what we had in the first place.
Yeah, I'd like to also emphasize that it isn't the quote manual to end all manuals out there for services, and that it's driven by the local initiative along with trying to get out information. I think, Nancy, you mentioned it, the word communication. If we could spread that probably around and get that accomplished, we may not all have jobs later on. It'd be great. We're kind of coming to the close. I kind of want maybe to summarize, Nancy, what you would want people to know about what's happening from your initiative and what may be in the future.
I'm not sure how to summarize that, but basically, I guess the 2 points that I wanted to make in this endeavor were that, number one, health really is an issue that is ongoing and is a basis for the well-being of our families, and so should be evaluated continuously, and health being both physical, mental, social, and we have to throw nutrition in there because that's part of physical well-being. And then the other part that I wanted to emphasize was that if we can put our efforts a little more heavily into the preventive end and the early identification, that we ultimately can hopefully work ourselves out of having to do the more intense wraparound services that these folks are involved with. Because if we can make our families healthier at an early age, we can hopefully ward off some of the later outcomes, negative outcomes of families that are too overburdened to survive.
Well, when we did some profiles just recently, we really looked at the family risk factors, and they were real similar in the sense that why the children were getting out of the system. There was physical abuse or sexual abuse or poor family health, educational issues that were running around, criminal issues, were not in all the scenarios, and that doesn't, say for all alternative residential. But there was a lot of those factors that what we looked at was no one did anything, or the resources that they were able to provide weren't enough to accomplish whatever that issue was, and the child then sequentially approached this more severe issue. And that's really where our model then, we looked at wraparound, came from the health side of this, which was nursing care, which is if we could give medical services at a lower level of intervention versus waiting for you to get so chronically ill, we put you in the hospital and the cost goes up, and we wait for you down there. We'll send some nurses out here and then try to do the prevention. And I think that's one of the things I'd like to leave people with too today, is also to think not at this far end, but how else do you get in the community and back up those preventative types of services to try to deal with our children and youth for the services that are needed now, not waiting for the $135,000 a year placement for some of the kids that we're talking about.
The other thing I'd kind of like to say is that Step Ahead is really a wonderful organization to incorporate this process of communication. I mean, that's what Step Ahead is all about. And it is, I think, in many counties well enough established that we can look at all of the folks that are working in care coordination. And that's not just our preventive and early intervention, and the school-aged efforts, but also the senior citizens. And we're all kind of trying to do the same thing, and if we can at a local level get people talking to one another, I think it's going to make the umbrella much more inclusive.
That's great to hear. Steve, you're the Step Ahead coordinator out in Hancock County.
Yeah.
How can you shed some light on Nancy's point there?
Well, I think it's just really important that Step Ahead has been a vehicle for people to sit down at the table and to start doing some planning. Just one example as far as to avoid duplication, it's a very small example, but I could see how something like that could expand would be someone came to our council meeting looking for funds or whatever to do a guide, a resource guide, kind of a care coordination guide, but a guide of what resources are available in Hancock County. And another agency said, well, we do one for our agency. Another one said, we do one for our agency. So we saw a lot of duplications just there. And so at that point, that Step Ahead became the vehicle for those agencies to sit down, and we made one guide and pooled the funds to do so. So we're hoping that that is like the beginning of the seed for a lot of other examples like that. So we can change the system by looking at what we're doing that's duplication and the fragmentation and seeing how we can connect all the two.
Okay, and Trace, your thoughts?
Well, I guess if I were to leave with one point, it would be that the philosophy of wraparound and the thinking behind it that we're using to serve the severe and multi-needs children and families, this same approach is, we're hoping, going to be just as effective with children with lesser needs. And I know many of the counties I talk to, what they want to do is start looking at issues like cross-training across the agencies, so that these techniques that we're using with a small group of people, eventually those techniques are bubbled down so that all of the caseworkers, all the probation officers, all of the therapists in the schools, all of them can use these kinds of techniques to help children when their problems aren't as severe. So that's where we'd like to get to.
Okay. And in closing, that's what I'd like to emphasize, is that in what we're looking at here is looking at children and youth in our communities and in our state. And if this was just in a small way helpful today to understand that there are some resources available at the state level and at the local level of some pretty dynamic people pulling together what may have been at one time an impossible thought, I would share with you that it is being done. It can be done. It sounds like there's some work that has to be involved, but also I would look at the other side, that there's a lot of work in our fragmented system that's going on that may not be as productive. And so what I want to share with you is that these are just some of the things that are happening on the state level. I think you heard that we're talking about process and things that are happening. By no means are we coming out and saying this is the only way to do things. So if you need additional help, you can get a hold of Nancy, me at the Department of Health, or myself at the Department of Education, or Trace and Steve at the local level in Hancock County. Thank you for being with us today, and we hope this was helpful.